Hello, Pebble is my name. We're discussing Polycystic Ovarian Syndrome, abbreviated as PCOS. Or some people call it Polycystic Ovarian Disease, that is PCOD. We are going to look at a number of things about these conditions, and then also urge you to read more about these very important conditions. We're going to look at the incidence of polycystic ovarian disease. We're also going to look at how we are going to make a diagnosis. How do we make a diagnosis of Pickles? And we'll try to look at the path of physiology. How does it occur? How does the condition occur? Pathophysiology of Pickles. And in this pathophysiology, we're interested in looking at how the gonadotrophins play some roles. The gonadotrophins, particularly LH and FSH, how do they play a role in this disease? We'll also look at how insulin resistance, abbreviated in these cases IHRA, play a role in these conditions. We'll also try to look at how the sex hormone binding globulins will play a role in these conditions. And then we look at how the androgens itself, the androgens which is actually the hallmark of the presentation, how the androgens will play a role. After that, we'll also look at how does the condition present, the signs and symptoms of the conditions. How does it present? What are the long-term and short-term risk? Long-term and short-term risk associated with polycystic ovarian syndrome. And then definitely we'll look at how we can manage the conditions, especially in gynecology, but also it will play a role in some of obstetrics. So see how the condition actually affect some obstetrics cases. So management, how do you manage it? So let's look at the incidence. The incidence for PCOS is about 4 to 12% of the total population. So that means that in reproductive age women, you find the incidence actually from 4 to 12%. This incidence depends on a number of factors. One of them is that it depends on the criteria used for diagnosis. If you use stricter criteria, you may actually find fewer women who actually fit the diagnosis of polycystic ovarian syndrome. If you use other more relaxed criteria, we'll actually see that the incidence may be higher in the population. And also this incidence depends on the ratio. It depends on the races. In some races, you find that a typical features of it, that is asceticism, is more expressed. So that means the diagnosis can easily be made compared to other races where you find that asceticism is, expression of terminal air in the women is very scanty. So that also depends on that. But what we need to remember is that is one of the most common endocrine disorders in a reproductive age woman. PCOS does not only present to a gynecologist, it presents to a number of specialists. So it's important that we need to remember this condition very well. Many people go to a dermatologist with a lot of pimples, and some of those actually may be polycystic ovarian syndrome. So that is something that can present to a dermatologist, including even people who present with a lot of body hair that are in a male pattern. We call that asceticism. So those women actually present to a dermatologist. To a physician, they can present with hypertension, insulin resistant diabetes, that type 2 diabetes. So they can actually present to physicians as well. But for this discussion, we're only concentrating on Polycystic Ovarian Syndrome presentation to a gynecologist. How do we make a diagnosis of Polycystic Ovarian Syndrome? The diagnosis, there are about 3 criteria that are used for making diagnosis. We have the most widely used Rotterdam Criteria. And this Rotterdam Criteria was actually formulated in 2003 when a consensus of European Society of Reproductive Endocrinology and then American Society of Reproductive Medicine at a meeting in Rotterdam in Netherlands. They were able to come with this criteria. This criteria is more relaxed. That means that it can actually accommodate more diagnosis of polycystic ovarian syndrome. And it's easy to use. You need to actually meet 3. Out of the 3, you need to meet 2. Let's look at the Rotterdam Criteria. Rotterdam Criteria. There are 3 of the three criteria here, but for you to have a polycystic ovarian syndrome, you must meet 2 of the 3. One of them is actually oligo or anovulation, which is characterized by oligomenorrhea or amenorrhea. In this case, we'll define oligomenorrhea as having less than 8 cycles, 8 menstrual cycles in 12 months. So that's what it means by oligomenorrhea. Amenorrhea, this is oligo. Amenorrhea means that you have, amenorrhea means that you should have at least missed period for 3 consecutive months. If you miss period for 3 months and you're not seeing it, we call that amenorrhea. So if you have any of the 2, you actually have features of oligo or anovulation. That's criteria number 1. The second criteria is that you should have androgen excess syndrome. Signs of hyperandrogenism. So this can be elevated levels of androgens, testosterone, T4, which is trihydro, testosterone, and then maybe DEAS, epiandrosterone sulfate, the sulfated form of the androsterone. So it's important that you need to know about this. You can actually do assays of that. These are what we call biochemical. So when you do a blood sample and you realize that the levels of the androgens are in excess, you can actually, that patient qualifies to meet the second criteria. Or you could actually signs of hyperandrogenism. That means that you have clinical features of excess androgens in a woman. And one of them is actually just you should have asceticism. You need to read how we can score someone, a woman, to have asceticism. Go and read about that. Or you can actually have acne. The other thing that can present and as a sign of excess androgen is acanthosis nigricans. That's a thickened, leathery appearing of the skin of the neck. And that's a sign of excess androgens, especially that comes also as a result of excess insulin, hyperinsulinemia. So for you to, the third criteria, let me write the third criteria here. whiteboard smaller. Let's say number 3 is here. This is Rotterdam Criteria. The third criteria is features of polycystic ovaries or polycystic ovarian morphology. In this case, you should have at least more than 12 follicles, especially the antral follicles. And this should be in a diameter of 2 to 9 millimeter. And they normally appear like a pearl, like a rosary. So if this is the ovary, these follicles appears at the edge of the ovaries. These are actually follicles that has failed to reach maturation. So they grow, instead of maturing and probably ovulating, they actually get arrested. They are follicular arrest, and that's a process that brings about the anovulation. So you could either meet this to have the third feature, or an ovarian volume greater than 10 cc. But this, you should make the diagnosis with this 10 cc or greater with caution, especially for a young person. A young person, normally, the ovarian volume is slightly bigger. But it's also one of the criteria for meeting the third options in the Rotterdam Criteria. So for you to have Rotterdam Criteria, you need to have any two of these three. And that brings about the controversy. So if you have oligo-ovulation or an ovulation with elevated levels of androgens, it means you actually have PCOS, even if you don't have polycystic ovarian morphology. So in other words, the name polycystic ovarian morphology, polycystic ovarian syndrome is like a misnomer. You don't need to have polycystic ovarian syndrome, morphology, to qualify to have polycystic ovarian syndrome. If you look at the NIH criteria, it's even more strict. They don't actually consider polycystic ovarian morphology at all. So you go and read about the NIH criteria, which is an earlier criteria that was formulated in 1990, and then a more recent one, the 2006 Androgen Excess in PCOS Society criteria for making a diagnosis. You can read about that. The NIH, and then the androgen excess and PCOS Society criteria. This is 1990, and this is 2006. So you could go and read about that, and it will actually make you give you more information. The second thing that we need to look at after this is the Path of Physiology. How does PCOS occur? The cause of polycystic ovarian syndrome is not completely understood. There are a lot of speculations that are there, but many is thought to be having some origin with the genes. It's thought to be a genetic thing, so it means it's actually inherited. And if you look at PCOS, the siblings presentations of PCOS is up to 66%. If you find PCOS, up to 66% of their siblings should be having polycystic ovarian features. So it will be good to also take some family history, look at the sisters, how are they presenting? Do they miss their period? Do they have beards? Do they have signs of excess androgens? So it will be good when you're taking history for PCOS. The other thing is that mothers of girls with PCOS, they are 50% more likely to also have features of PCOS. Yes. So that's some important information that pins this towards the the genetic origin. And there are some candidate genes that has already been found, especially genes related to the synthesis, metabolism, cholesterol, metabolism of steroids, especially cholesterol, converting cholesterol to steroids. So that is very important. But also environment plays some important role. It's not just purely the genetic bit of it, it's the environment. What is understood is that most people with PCOS have some bit of insulin resistance. And this insulin resistance is thought to be the one that drives features of polycystic ovarian syndrome. You know, when you have insulin resistance, that means that you need a slightly higher level of insulin to effect work. That means you actually need you're actually intolerant to glucose. So most of the diagnosis of insulin resistance is actually found when you're doing glucose tolerance test. Now, this high level of insulin that is built within the body system actually alters the GnRH pulse frequency. In another lecture, we'll look at the coordination between the gonadotrophin releasing hormones and then the pituitary hormones and then the ovaries. And that's what we call the hypothalamo-pituitary ovarian axis, the HPO axis. Very interesting axis that coordinate this. But for now, what we need to know is that GnRH is produced within the hypothalamus, and this influences the production of the pituitary hormones. Majorly, we are considering in this lecture is the LH and then the FSH. Now, this LH and FSH acts on the ovaries to effect changes. And for the interest of these lectures, we are trying to look at only two cells in the ovary. That is the thecal cells and then the granulosa cells. The granulosa cells as receptors for follicle-stimulating hormones. And then the thecal cells as receptors for luteinizing hormones. Normally, when GnRH releases the pituitary hormones, LH actually acts on the thecal cells in the ovary, and this brings about production of androgen. This androgen is acted upon by the follicle-stimulating hormones within the granulosa cells. And this is converted to estrogen. And the body programs that the LH and FSH are produced in the same ratio, the ratio 1 to 1. Now, in polycystic ovarian syndrome, this is altered. That means that the insulin resistance causes alteration in the production of GnRH. So when this is altered, that means that the pituitary hormones are produced, but in this case, LH is produced more than FSH. And this means that the ratio actually sits 2 to 1. So if we apply this rule, it means that within the ovaries, LH produces twice the actual amount of androgens, and that means androgens keeps accumulating in the system, And excess androgen within the ovaries is thought to be one of the factors that cause follicular atresia. So the follicles grow, they cannot reach maturity, they actually stop growing, they actually become atresia. Follicular atresia will be achieved, and at the end of the day, they cannot be ovulated. And this is thought to drive the features of polycystic ovarian syndrome. So this relates how insulin resistance actually affects the production of GnRH and the gonadotrophins, especially the LH and FSH. And this is also related to how the androgens are produced. Now, the sex hormones binding globulins. Insulin resistance is thought to reduce production of sex hormone binding globulin within the liver. These sex hormone binding globulins have very important roles. What do? They actually bind free androgens from the system. After binding them, that means that they become not available. So in case they are not bound, the androgens are not bound, they actually have a chance of binding to their receptors. And that brings about the effect of the androgens. So there will be free androgens that circulate in the system, and this, when they reach the skin, they actually bind to the skin receptors, causing production of sebum, increasing production of sebum, and that brings about the acne. Or stimulating the production of air, changing the vellus air to a terminal air. So that means that the tiny air that are on women can easily be turned into terminal air, especially on androgen sensitive sites, and that brings about the asceticism. You have seen women who can actually present with some scanty beards, one or two, still effective enough to make a diagnosis. Or a mustache, sideburns. So you need to read how you can actually be able to score this. So basically, that's how PCOS comes about. You need to remember insulin resistance, excess androgens, changes in LH and FS, but because of there's a change in the pulse frequency of the GnRH, and then reduction of level of production of sex hormone binding globulins. We need to remember that. How does this condition present? Signs and symptoms. Presentation. We've said that PCOS present with features of excess androgen. So that means many of these people actually present with features of excess androgen. And one of them is asceticism. Asceticism. Acne. But this presentation may not be important for you, but it will be an important clue to a signs of excess androgen. But most of this is actually presented to either dermatologist, or someone who has interest in cosmetic. Our typical presentation is amenorrhea. Many people come with amenorrhea. That means they can actually miss period for greater than 3 months. Or oligomenorrhea. Oligomenorrhea, that means that they have less than 8 cycles in 1 year. Some people also present with abnormal uterine bleeding. We'll discuss how the abnormal uterine bleeding comes about. Let me put it here. AUB. That's abnormal uterine bleeding for discussion. So that means that they come with bleeding that does not follow a pattern. It's really not like a menstrual flow. The other presentation that occurs is that many of them present with inability to get pregnant, infertility, or sub-infertility. They find it very difficult to get pregnant. They may be able to get, but it takes them long You've seen some couples that have produced only 1 or 2 children, and then you say, oh, it's probably they have only the eggs, or that was the only gift given to them. The other features that are there are recurrent pregnancy loss. We are going to discuss about recurrent pregnancy loss, and as well as infertility. How does it come about in polycystic ovarian syndrome? Before we discuss those, it would be good to mention early and late complication of polycystic ovarian syndrome. Early complication. Then you can have your late complication. SUCX is a complication. The early complication will be recurrent pregnancy loss. Recurrent pregnancy loss. Infertility. Can also cause anemia, especially iron deficiency, anemia, due to the abnormal uterine bleeding. These are complications that occurs. But of course, you may also need to consider things like cosmetic issues. As a complication. Looking at the social, how social we are now, people are more interested in their appearance. The late complication that you may remember, and this would also tell you that PCOS is not just an acute condition that you should see the patient and forget about. You should have a long-term plan for this patient. The late complication that might occur is because of the high level of androgens that may actually predispose these patients to cardiovascular disease. They are more likely to have hypertension in their life. They are more likely to have diabetes type 2. Remember the insulin resistance theory we talked about earlier? It can actually bring about diabetes. Many of these people actually have obesity. It's not that all people with PCOS present with obesity. We've seen lean people with PCOS. But quite a number of them are obese. And you have also seen in some family, they say, for us we're big, for us we're big. It is probably you have a big gene, a gene that actually causes the bigness. It may actually be a polycystic ovarian syndrome. Not all obese people, big people, have PCOS. But quite a number of them would actually have PCOS. Endometrial carcinoma. See endometrium. Very interesting. The unopposed action, because the woman with PCOS, they have either oligo or an ovulation, they do not produce progesterone that opposes the action of estrogen on the endometrium. So unopposed action of estrogen on the endometrium more likely to predispose someone to cancer of the endometrium. So we may need to remember this and probably need to have a long-term plan for any patient who comes with polycystic ovarian syndrome. Let's briefly look at how does AUB comes about. We have our endometrium, and then probably have our ovaries somewhere there. This is the endometrium. Of course, this is the uterus, and then the endometrium is this lining I'm trying to shed. So what happened is that when you have PCOS, you produce estrogen from here. The estrogen causes proliferation of the endometrial lining. Aside from other functions, it has a lot of functions that we cannot exhaust it even in this. But we're interested in what happened within the endometrial lining. For it, it causes changes, proliferation of endometrial lining. Now, these changes is supposed to be counteracted by progesterone when there's ovulation. You know, progesterone is produced in the luteal phase. That's the progesterone dominant phase of the menstrual cycle. But in the absence of progesterone production, in the absence of ovulation, that means you do not have a progesterone. You have an opposed action of estrogen. That means that you have erratic proliferation of the endometrial lining, and this is prone to breakthrough bleeding because of what they call estrogen breakthrough bleeding. And when this occurs, you can actually have either spotting or a very heavy flow. And some people actually present with iron deficiency anemia. Let's look at infertility. We have said that in the ovary of a PCOS woman, because of the increased production of androgens, and much of the androgens are not converted to estrogen, within the ovaries, the high level androgens are not good for follicular growth. So the follicles grow, instead of getting ovulated, they actually stuck at the outside wall of the ovaries. And when they're stuck there, they actually make the ovarian volume bigger and bigger and bigger. Now, what happens? Because there's no ovulation, that means that there's very few ovulation. That means that your chance of getting pregnant is almost, if there's no ovulation, the chance is not there at all, or it's actually reduced when you rarely ovulate. And that brings about the infertility. But also aside that, because the eggs are growing under very unusual conditions, once in a while a woman can ovulate, but these poor quality eggs may not actually be of quality so that it can be fertilized. Even if you get fertilized, many of these women end up into chemical pregnancy because of a defective corpus luteum. The corpus luteum may not produce enough progesterone to maintain the inner lining of the uterus. And that means they either are not able to get pregnant or get an early chemical pregnancy loss. That is a pregnancy that can only be detected by beta ECG. Even if you do a scan, you may not be able to see anything. There are no clinical features of this pregnancy. And these theories also explain why you have recurrent pregnancy loss. It's thought because these follicles are growing under a very unusual condition, and because they are growing under unusual conditions, they have poor quality. And you know, human reproduction is about quality. If there's a defect in any of the gamete, processes are engineered to stop the growth of abnormal fetus. It may also be related to the recurrent pregnancy loss, may be related to the recurrent pregnancy loss, may be related to luteal phase defects or deficiencies. The luteal phase deficiency is very interesting. We'll also have a discussion of how the luteal phase deficiency occurs. It's not only brought by polycystic ovaries, a number of conditions can actually bring about fallopian phase defects or deficiencies. Just quickly, let's look at how you can treat polycystic ovarian syndrome. We've seen that it presents with varied conditions. One of them is infertility, abnormal uterine bleeding, amenorrhea, hirsutism, acne. So because of this, we may need to plan and see how you can treat it. Because if a woman is interested in preventing maybe bleeding, and she's not interested in getting a baby, your objective should be geared toward treating maybe the bleeding, preventing the bleeding. If a woman does not see a period and she's interested in getting a monthly cycles, your objective should be towards that. If they're worried about the hirsutism because of their cosmetic appearance or as acne, you can actually gear the treatment towards that. If they're interested in fertility, you actually gear your treatment towards that. So you must set an objective with the patient. What is their interest? What is their current interest? And what is their future interest? And you should be able to also discuss, before you manage this patient, the long-term risk associated with this condition, so that they should not just forget. There should be a clear follow-up plan. If you're done as a gyne or in a gyne unit, and the patient has no interest in this, probably they need to be followed up by the physicians. Look at the risk of getting diabetes. Look at the risk of getting hypertension. But also in future, you should be able to do a follow-up to avoid things like endometrial carcinoma. So there should be a clear follow-up plan for that. Now, how do you treat PCOS, infertility? I must say that not all people who have PCOS are infertile, but quite a number of them would actually have difficulties getting pregnant. Or even if they get pregnant, they have difficulties in maintaining the pregnancy. We've already discussed about recurrent pregnancy loss earlier on. So we need to see how to help them. The primary things is in the treatment of PCOS is that we should be able to cause an ovulation. And when we are interested in making a woman get a baby, we should be able to cause an ovulation. How do we cause an ovulation? There are many things that can be done to cause an ovulation. We can use the usual medicines. Of course, the success is not. We can use clomiphene, citrate. We can also use an aromatase inhibitor, like the letrozole. We can use an insulin sensitizers. In our market here, we have already 2 insulin sensitizers. Although it's not approved, but people have started using them a long time ago. And one of them is actually metformin. Metformin is a drug which is used for treating diabetes. Sometimes when you prescribe this, people will just stop you. They think you're giving medicine for diabetes. You know how people normally think. The other insulin sensitizer is inositol. You can go and read about how inositol causes the insulin receptor sensitization. We're going to read about that. So sometimes this all fail. You could actually consider using maybe beta ECG shot, and sometimes you may actually require you to do assisted reproduction. ART, assisted reproductive technology. That means you need to do super ovulation, super induction, and then harvest the eggs, and then do an IVF kind of sort of work. So that is the treatment options that we have. But of important is that when you put these women on metformin and you put them for long, they are more likely going to change. All these other parameters will change. That means the IAUB will actually reduce. The amenorrhea may also go. Hirsutism acne will disappear. So maybe this is a good candidate if you put it for long. And this candidate can also be used to prevent recurrent pregnancy loss. There are studies that shows that when you maintain a woman on metformin up to 8 weeks of gestation, those mothers are likely to maintain their pregnancy compared when we withdraw. So withdrawing metformin gives them a risk of losing pregnancy. So you can actually use that as a way of doing that. Okay? If a woman has recurrent pregnancy bleeding, recurrent pregnancy loss, you could actually do a luteal support, and also, of course you need to start them early on metformin to maintain them until 8 weeks, and then you do a luteal support until when the pregnancy is between 14 and 16 weeks. For AUB, it's important that you need to bring back. You can actually stop the bleeding with a simple medication, and that is progesterone. Because AUB, we discussed that progesterone is missing. Just put your progesterone there. In our market here, we have norethistron. I'm not going to talk about the trade names, but we have norethistron that are there. When you put them back, the bleeding will stop. Sometimes they also use tranexamic acid to aid. A combination of progesterone and tranexamic acid makes the bleeding even stop a little bit faster. But you could actually plan to put them on cyclic progesterone. The cyclic progesterone means that you remember they don't ovulate. That means they don't produce progesterone. So you put progesterone in the cycles. So you give progesterone 7 to 10 days every month. If you start maybe on the 30th, this month, next month you start on the 30th, the other month you start on the 30th, like that. Of course, next month, here's next month, 30th, like that. So they take it for 10 days, 7 to 10 days, 7 to 10 days. That's what they call cyclic progesterone. It works wonders. You could also consider giving COC, combined oral contraceptives. This is for AUB. And this also works for amenorrhea. So all of them are the same. Cyclic progesterone, COC. Interestingly, COC actually helps the liver to produce more sex hormone binding globulin. So that means that the excess sex hormone binding globulin produced will bind most of the steroids, most of the androgens in the system. So that will actually relieve the system from that. Hirsutism, you could consider giving metformin, but of course you need to give it for long, at least for 6 months. When a woman is taking metformin, it's not that the hair will disappear. The hair that's already grown will remain there until it grows old and stop. But no new hair is being formed. That's a good news. So if the hair is supposed to grow for how long? How long does the hair supposed to grow? Okay? To remain intact. So until that hair falls off. But there are also other options that are there. Maybe you can do a laser removal of the hair. You could do a flornithine, which is also a drug that can be used for removing hair. But that is not your work. That's the work dermatologist. So when it comes to the asceticism and the acne, it would be good to consult a dermatologist to have option. Otherwise, this is about Polycystic Ovarian Syndrome. I want to thank you so much for taking your time to watch the YouTube video. I want you to subscribe so that you get all the updates, all the lectures that we'll be able to produce. And then you also give your comment how we can make it better.